We're going to set up the patient on the ventilator. So first couple things we got to do is we need to decide how big he is. So can somebody tell me how tall Patrick is?
5'11".
It's 5'11". So what does that mean from, and we set patients up using ideal body weight for kilograms. So can one of my students tell me what his ideal body weight is in kilograms? There's a formula we use as respiratory therapists.
78.18.
So he's about 80 kilograms of ideal body weight. So the reason we use ideal body weight when we set up someone on a ventilator is because it doesn't matter how much mass they have around them. It's all based off of how tall they are, is how big their lungs are. And he's a male, so it was based off him being a male and how tall he is. We normally set them up at about 6 to 8 milliliters per kilogram of ideal body weight. So if he's 80 kilos and I want to do 7 milliliters, what do we got for a tidal volume?
560.
Thank you. So I'm going to put him on 560, and that's right in the middle range for what he should be at. We want to keep in mind that he is an asthmatic, and because he's an asthmatic and he's in severe asthmaticus, he's probably going to have a lot of trapped air in his lungs. So I may even want to go a little bit lower than that once I get him on the ventilator to make sure that he is adequately being able to ventilate without popping his lungs, because we could easily blow a pneumo and give him some barotrauma with any type of volume we try to push into him. The other settings we got to do is we got to set him up on a respiratory rate. A normal rate when we put someone on a ventilator is somewhere between 12 to 14-ish, so I'm going to put him on 14. So for Patrick, because he's an asthmatic and he's in the middle of a status asthmaticus attack, he's already going to have a lot of intrinsic PEEP already. His airways are obstructed, air is going to go in, it's not coming back out. So he's probably got a ton of intrinsic PEEP when I put him on the ventilator. So I'm going to try to turn his PEEP up a little bit when I start, because it's easier for him to not have to add more on top of that if we start him at the same level he's already at. So I'm going to start him at a little bit higher than I would normally, and I'm going to start him at 100% oxygen. So typically what we like to do is we like to match the FiO2. So if he was getting 100% when we did this, we're going to put him right on 100% when we start.
And the last thing was PEEP, so everybody remembers what PEEP is. And so I think he's at 8 right now.
Yeah, he's at 8.
So for nursing student, I mean, RT is the one setting up the ventilator, but we're the ones that are going to be checking what the settings are based on the orders. So we need to know what those type settings mean.
So what you see on the ventilator here, I'm going to run through it all. Down in the bottom half of the screen, those are the settings that the respiratory therapist actually sets. The top half of the screen is what the patient is doing. So all the numbers up there are coming directly and being measured from the patient. But right here is the frequency, so that's your rate. The next one is your volume. He's set on 400 milliliters for a tidal volume. The next one here is a flow rate, which really isn't a setting, it's something that we play with. And the flow rate, what it does is it helps determine how fast the breath goes into the patient. So for someone like Patrick, for example, I would want a higher flow rate because he's going to need a longer time to exhale. So we want the breath to go in very fast, and then we want the exhalation to be really long to allow all those obstructive airways time to get rid of anything that's in there and it's been obstructed. This is your oxygen, and then your PEEP is set here. The top one is his numbers, so we can see what his peak airway pressures are, what his mean airway pressures are, and then there's a bunch of other ones along here. This is his exhaled volume and his exhaled minute volume, which right now it's showing that he has some type of an air leak because we're not returning 400 cc's that we're putting in. We're only returning about 260.
Okay, so everyone that had SHA-1, think about what would cause a high pressure alarm and what would cause a low pressure alarm.
Like low pressure is a leak, right?
Yeah.
High pressure, ink or something.
So I heard you guys kind of brainstorming on your side, so they were really good with that. Low pressure alarm would be a leak of some sort. It means that for whatever reason, when we deliver a volume, it should reach a certain pressure. If it doesn't reach that pressure, it's leaking somewhere. But the leak can come from a lot of places. So the leak can come from around the tube. It can be within the tubing itself. It can be from the cuff. It can actually be from the patient. So the ventilator itself will, when it registers stuff that's happening, if there's enough of a leak in the patient, it can register as a low patient pressure alarm as well. And that happens generally when there's a chest tube and there's a very large patient leak. Other high pressure things are directly related to the patient's lung status itself. So things that we worry about that are not like fixable like immediately. A kink in the tube, we can unkink it. We can fix some of that. But Patrick in particular, since he's an asthmatic patient, is probably going to have higher lung pressures. So when they have higher airway resistance and a lower lung compliance, so means their lungs are less elastic, they're kind of stiffer, they're going to have higher peak pressures, and that can cause the alarms to go off. If it goes off a couple of times, it's not usually a big deal. It probably was him coughing, him moving. When it starts to go off consistently, as it's going to do now, as a nurse, what would you do?
See if there's a problem with the lines. See if
Check
there's
the
any
oxygen
leaks or-
equipment.
We're getting closer.
Look at the connection.
So from a respiratory therapist standpoint, what you want to do as a nurse, whenever there's something on the machine and it continues to do it and you don't know what it is, remove the machine from the equation. Call the respiratory therapist and bag your patient until they get there. That's the best thing to do in any of those situations. If you don't know why it's alarming and what's happening, take them off, bag them, because you know how to bag the patient, you know what to do, you know exactly how that goes. It's a better thing to do until the therapists get there. So call for help, assess, and bag the patient all at the same time.